Thank you for this kind invite to share my thoughts on the coding challenges in cholangiocarcinoma. I'm a hepatobiliary surgeon in Liverpool, UK. So cholangiocarcinoma is a cancer of the bile ducts, and it can be classified as an intrahepatic tumor, which is a mass within the liver itself, a perihilar tumor, which is a tumor where the liver and the bile ducts meet, and a distal tumor, which is a tumor mainly in the region of the pancreas gland. And the latter two often present with biliary obstruction, so patients become jaundiced, and they may be admitted and have procedures to relieve the jaundice, for example, an ERCP. And this is a schematic demonstrating the anatomy of cholangiocarcinoma. Now, the perihilar tumor is the most common tumor, compromising approximately 60% of the subtypes of cholangiocarcinoma. However, previous studies in the West mainly have suggested that the incidence of intrahepatic cholangiocarcinoma is higher than perihilar cholangiocarcinoma. And if you look at the English Cancer Registry, the perihilar tumors are coded in a number of different ways, which makes identification of these patients challenging. Now, why is it important to get coding right? Well, firstly, it allows us to better understand the epidemiology of the disease. It also skews the mortality rates and the incidence of disease if we get the coding wrong. And of course, we're interested in future research to improve patient care, and we need to know which patients we're treating, so coding is crucial to that. But as a surgeon, if I look at the operations that I undertake, the surgery for an intrahepatic tumor is this. You access the abdomen, you mobilize the liver, you resect that part of the liver, and then you close the abdomen. This operation can take 2 to 3 hours. Patients will be in hospital for approximately 5 days. If you look at the perihilar tumor, the surgery for this is far more complex. It involves resection of the liver, the bile duct. It can often involve vascular resections and reconstructions. This is an operation that takes 10 to 12 hours to do. Patients often will go to intensive care. It's associated with significant morbidity and risk of mortality, and patients are often in hospital for up to 2 weeks. A distal tumor will involve resection of the pancreas, and again, the operation is fundamentally different. It involves mobilization of the pancreatic head, division of the pancreatic neck, removal of the tumor, and a reconstruction. So crucially, getting coding right allows the hospitals to bill for what they've actually done, and that is actually important for the NHS. So the latest iteration of coding does actually, for the first time, identify these 3 types of distinct cholangiocarcinoma variants. So the intrahepatic cholangiocarcinomas are here, and this is the tumor within the liver substance itself. The distal tumors, which often involve a pancreatic resection, are coded differently, 2C15.0. And crucially, for the first time, the perihilar tumors are coded with their own specific code, 2C18. Thank you very much for your time.